So good morning, everyone, and welcome to day 2 of the 2023 Department of Family and Community Medicine Conference. My name is Allison Merbaum. I'm the Faculty Development Program Director in the DFCM and the chair of this year's Conference Planning Committee. I'm delighted to welcome you to this morning's event and building on the tremendous success of yesterday's in-person event, where approximately 200 of our faculty joined together to learn from and with one another. Please feel free to introduce yourself in the chat, where you practice, your role in the DFCM, so we have the opportunity to get to know one another and see who is participating today. The planning committee for this event chose the title DFCM, Strengthening Health Systems Through Academic Excellence, Connection, and Collaboration. This aligns with the vision of our new departmental strategic plan of outstanding primary care for all, powered by world-leading research, education, and innovation. I would like to start by acknowledging the land on which we live and work. No slide, please. As well as recognizing our place on this land that we share with one another and our patients and our communities. I am a non-Indigenous person of white settler ancestry. Like many of you, I'm on a personal journey of reflection and learning about our colonial history and the true meaning of reconciliation. The Truth and Reconciliation Commission of Canada defines reconciliation as an ongoing process of establishing and maintaining respectful relationships. Aligned with that definition, I wanted to reflect today on the concept of cultural humility and our responsibility as health professionals and teachers, as many of us identify teaching as our most important academic activity. There are many definitions of cultural humility, but this one resonated with me. Cultural humility involves an ongoing process of self-exploration and self-critique, combined with a willingness to learn from others. It means entering a relationship with another person with the intention of honoring their beliefs, customs, and values. It means acknowledging differences and accepting that person for who they are. Like many of you, my elementary and high school education was significantly lacking in Indigenous culture and history. And it's only been in the past several years that it has become increasingly apparent the responsibility that I, as an individual, a physician, a teacher, and leader, and I suspect for many of you that we have in learning and reflecting on our privilege as settlers in Canada and to approach reconciliation in the spirit of learning and growing. Living and practicing in North York, up until a few years ago, I would have said that although I have a very ethnically and socio-demographically diverse practice, I don't have any Indigenous patients. I have learned more recently that I do have Indigenous patients in my practice. I just hadn't recognized it. I had never asked and they had never told me. And this is so unfortunate because this information sharing would have strengthened our physician-patient relationship and my ability to provide more culturally safe care had I known or had I asked. And I wonder if these individuals didn't volunteer this information to me because they worried that it might have a negative impact on their care if they did. The story I wanted to share today is of a patient to whom I've had the privilege of providing care for 20 years. She's a woman in her mid-60s who lives with her 2 adult sons. She has several chronic health conditions that are stable despite not being on typical medications for them. In fact, one of her specialists had tried many times to convince her to take disease-modifying medication, but she had declined. I should have explored her views on pharmacotherapy further. One day, a couple of years ago, she was booked on my schedule for forms. I'm sure we all have these types of booked visits. You have no idea if the patient will arrive with extensive work disability forms or just need a signature on their application for hearing aids. In this case, she needed me to act as a guarantor, as someone who had known her for an extended period of time. When I asked her what it was for, she let me know that she was applying for her Indian status. I didn't know much about this, and that she could clearly see that I didn't understand why she was applying at this stage of her life. And she could, why, if she was of Indigenous heritage, she wasn't already registered. And she confided in me that she was a victim of the 60s scoop and took the time to explain a little bit about her childhood. She was born in downtown Toronto to an Indigenous mother and a white father. She was born with a visible congenital anomaly. And as a result, as she explained, her mother left. Her father sent her to live with his family, but she was not cared for well. As part of the 60s scoop, as it has been referred to, she was taken into foster care, placed with a Mennonite family, and then adopted by a white family at age 5. She told me that her adoptive family didn't tell her about her Indigenous heritage until she was older. Therefore, she did not have an opportunity to grow up learning about her own culture or history. She'd applied twice previously for her Indian status, but was denied as she does not have proof of her mother being Indigenous, although she does have a birth certificate with her mother's name. It's also important that to note that prior to Bill S3 being passed in 2020, she would likely not have qualified. This is because her Indigenous mother had married a white man before 1985, and her mother therefore would have lost her status. I learned that there are several reasons why this woman wanted to register now: to be connected with her community, to qualify for financial compensation for being a victim of the 60s scoop, and to allow her adult children also to be able to register if they wish in order to receive financial support and other rights and benefits that they may need in the future. This experience led me to read and learn more about the 60s scoop, and I'd like to share a little bit with you in case this is new to you as well. Patrick Johnston coined the term in his 1983 report, Native Children and the Child Welfare System. Although the practice of removing Indigenous children from their families existed before the 1960s, for example, to residential schools, the overrepresentation of Indigenous children in foster care accelerated in the 1960s, where children were taken from their homes and placed mostly into middle-class white Canadian families. In 1951, only 1% of children in foster care were Indigenous, but by 1964, that number was 34%. There continues to be a significant overrepresentation of Indigenous children in foster care currently. In fact, in 2021, Stats Canada reported that 53.8% of all children in care are Indigenous. There are, of course, many reasons for this, intergenerational trauma and poverty being significant contributors. During the 60s scoop, many Indigenous parents living in poverty, but otherwise providing caring homes, had their children taken from them with little or no warning and absolutely no consent. It wasn't until 1980 that the Child, Family, and Community Services Act required social workers to notify the Band Council if an Indigenous child was to be removed from the community. It is felt that apprehending children from their homes and families was a new form of cultural genocide following the dismantling of the residential school system. Since the 1980s, the adoption laws have changed to prioritize placing Indigenous children first with their extended family. If that is impossible, then by another Indigenous family, and the last choice being with a non-Indigenous family. Reflecting and learning from the patient's story has led me to probe deeper with other patients, actively listen, and consider the patient's past experiences with the healthcare system, culture, and values when providing care. I tried to do that before, but this adds a new lens for me. I share this story in my journey of learning with the hope that it might help others, and to share what I see as a practical way of approaching the Truth and Reconciliation Commission's calls to action in the day-to-day care of our patients. Next slide. So I've included some of the references I reviewed for this land acknowledgement, and please also take a few minutes to review the University of Toronto Truth and Reconciliation Calls to Action report of 2020, which highlights the university's approach in this regard. Moving on to the conference agenda, here is how the rest of the morning will shape up. In just a moment, we'll hear from our recently appointed Vice Chair of Research, Dr. Peter Selby, and his Earl Dunn lecture entitled Research Innovation for Impact in Family Medicine, The Way Forward. At 9:45, our chair, Dr. Danielle Martin, will introduce the panel discussion entitled Health System Leadership, Advocacy and Action, featuring members of the Office of Health System Partnership and Ontario Health's Vice President of Clinical Programs, Rose Cook. For our final segment of the morning, we have 10 amazing workshops. Hopefully you've chosen one of the workshops, but if you haven't, please refer to dfcmconference.ca website for the corresponding Zoom links. We will remain on the current webinar link until 11 a.m. and then transition over to the workshops at that time. Again, please refer to the conference website and Eventbrite emails for the appropriate links. I did want to say a note of thanks to our conference planning committee, including Dr. Barney Giblin, who unfortunately passed away this year. We also, our abstract vetting committee reviewed over 70 abstract submissions for both yesterday's in-person event and today's event, and I really appreciate their support as well. And of course, our staff volunteers with whom we could not be able to coordinate these kinds of days, and many of whom volunteered and attended our conference yesterday, and others who are helping and facilitating today. We'll now move into our keynote presentation, named in honor of Dr. Earl Dunn, to celebrate his work as one of the top pioneers of telemedicine and research in family medicine in Canada. He joined University of Toronto's Faculty of Medicine in 1968, and his work greatly advanced family medicine in Canada and internationally. Each year, this honor goes to a DFCM faculty member whose research continues to advance primary care. For this year, our planning committee had the wonderful idea of welcoming our new Vice Chair of Research, Dr. Peter Selby, into his new role through this lecture, and to share his vision for the future of primary care research in the DFCM and beyond. I'd now like to introduce Dr. Aisha Lofters, who will introduce Dr. Selby and moderate the Q&A period immediately following. Aisha is a scientist at the Women's College Research Institute, adjunct scientist at ICES, and an associate professor in the Department of Family and Community Medicine. She previously held a New Investigator Award from the Canadian Institutes of Health Research, and is the medical director and chair in implementation science at the Peter Gilgan Centre for Women's Cancers at Women's College Hospital, in partnership with the Canadian Cancer Society. She was recently the recipient of the 2021 Canadian Cancer Society Inclusive Excellence Award. Her research program focuses on improving quality of care in cancer research and prevention, particularly for populations that experience marginalization through a variety of methods, including community-partnered approaches. So welcome, Aisha.
Thank you so much, and it's my pleasure to be here this morning to introduce, Dr. Selby. So I'll first start out by reading his official and very impressive bio. So Dr. Selby, who many of us know, is a senior medical consultant and clinician scientist at CAMH. As was just mentioned, he is the Vice Chair of Research and Giblin Professor in Family Medicine Research here at the University of Toronto. And his research focuses on innovative methods to understand and treat addictive behaviors and their comorbidities. He uses technology to combine clinical medicine and public health methods to scale up and test health interventions. His cohort of over 350,000 treated smokers in Ontario is an incredible example of this. And he's received grant funding totaling over $100 million from CIHR, NIH, Ministry of Health, and has published over 200 peer-reviewed publications and counting. His most recent program of research utilizes a learning health systems approach, very relevant to all of us today, to investigate how technology, equitable, collaborative care can enhance the delivery of evidence-based interventions to the patient while providing a more satisfying experience of care for patient and provider. So that's Peter's very impressive bio on paper, but I think what matters even more is that Peter is kind, he's humble, he's always willing to find time in his very, very busy calendar to chat, to synergize and think of ways to support others. So I think that's what we all love most about Peter. So very excited to hear your talk today. And Peter, please take it away.
Thank you so much, Aisha, for that very kind introduction and kind words. And I was almost looking over my shoulder, wondering who you were talking about. Yeah, thank you. And again, congratulations to the planning committee. Yesterday was just fantastic. I think just what our souls needed to learn, stimulate the brain, stimulate the heart, meet people again. So thank you so much to the planning committee. Allison, fantastic job. And I know it took a village to make it happen. So thanks to everybody who was involved. So I'm going to try to share my screen and hopefully I don't mess it up, but we will see if I finally got it right. Okay, so I trust everybody can see it. If somebody wants to put in the chat that it's good, that'll be wonderful. So I was asked to talk about research innovation for impact in family medicine, the way forward. And I want to point out that if you need to get in touch with us, a couple of ways. One is there's an email, dfcm.research@utoronto.ca. That's generic. That goes to Tarani or Tara Jairam, who's our research program assistant, and definitely we'll get back to you if you have any questions. And of course, please check out our website and do join our listserv if you haven't already joined it. In terms of disclosures, I have financial relations with financial sponsors are primarily non-profit organizations and granting agencies. I, in the past, have been invited for talks that were actually that were honorary and provided by companies, but I did not. Obviously, the information and what I presented was not subject to their approval, and the payments were made directly to them and then on to ChemH. I've done consulting fees similarly in the same way for primarily technology-based companies, as well as bringing new medications for addictions to Canada. But nothing in the last 5 years. The other disclosure I want to make is because I run the STOP program for the Ministry of Health, we go through an open tender process and companies compete and make bids. And through that process, we buy nicotine replacement therapy for the province. And it's a very open and transparent process. And it's held at ChemH. I am not involved in the final purchasing decisions, but just thought I should disclose that. I do not take any funding from tobacco, vaping, alcohol, or food industry at all. In terms of financial support, I hold the Vice Chair Research and Giblon Professor in Family Medicine Research. Very, very grateful to Beverly and Barney Giblon, and really sad with the passing of Barney. Barney was a great supporter of me right from when I was a resident, and I was really honored to be able to carry on this professorship. And I hope what I do during holding this professorship it makes him proud and his family proud. And of course, I've received in-kind support from my DFCM and ChemH staff for getting these slides ready and data collected for my talk. How do I plan to mitigate bias? It's really by being transparent and using the best available evidence when I talk about things. So coming back, thank you very much, Allison, for that really meaningful land acknowledgement. So I'm an immigrant settler in this country, welcomed in 1990, and have been very fortunate to have landed up in this position where I find myself. But back since 2000, I have been working with Indigenous organizations, communities, primarily on restoring tobacco to its rightful place, moving away from commercial use of tobacco to the traditional use where appropriate. And so as part of our reconciliation projects that have been ongoing since then, before the TRC came out, but we continue, is to co-develop a training toolkit with First Nations. It's using the OCAP principles, so it's available to anybody for free, and it's not pan-Aboriginal. So you can see that it is has, for example, an Inuit toolkit, which is completely different. And again, those are the ways in which it's done. And we try to make sure that we train capacity and make sure people who train are actually from the communities or people who identify as such. In terms of the STOP program, which I'll be talking about, we work in partnership with many Indigenous organizations and have built trust. And again, using principles where we are in support of their activities and their desires, we do that. As well as operationalize an anti-race and anti-oppression working group in the workplace, as well as sex and gender working group. And a lot of my work is inspired by an Indigenous Center of Excellence at ChemH called Scabe Makwa. I'd invite you, as you are coming through, is to identify where you're joining us from today. If you're not sure, there's a link there on whoseland.en to find out where you are. I'm in Treaty 13, that covers with the Mississaugas of the Credit, which covers Toronto. And then really ask yourself, what is your reflections with the land and the history and stewardship, and then think about how past and ongoing oppression and colonialism affected and affects Indigenous communities to this day. And I think Allison's story is exactly where we should be opening up our hearts to listen more closely. Of course, I really feel that I've been inspired by the work of Dr. Earl Dunn, because is the father of telemedicine. Some of my innovation and some of the work that we do is clearly been inspired. And so I always think that when we, when we do anything today, we are standing on the shoulders of giants that have come before us and have created and prepared a fertile environment for us to thrive. And if you want to hear that, there's a link to that YouTube video as well. So what I'd like to talk about is really three things. What is family medicine research? Family medicine research is critical for real world answers. It's not a question, it is. But that's what people will ask. Is it critical? Do we really need to invest in family medicine research? And then as family docs, we need to use innovative out-of-the-box thinking to solve problems and tell others about it. Because essentially that's what you have to do every 7 to 10 minutes in your busy clinical day, where you don't have the time or there isn't the evidence to actually inform you how to manage that situation. And you have to rapidly task shift from thinking about one thing to the other. So it's different because, so anyway, we'll talk about that as we go through. I really like this quote from Maya Angelou. Do the best you can until you know better. Then when you know better, do better. And I think this is one of those things about when you know better, do better. But again, I would add that to be able to do that, we need environments that can certainly promote doing better, even though we know to do better. Otherwise, it just becomes an exercise in frustration. So to do better, we also need to make sure the environments are prepared so that we can do better. When you're coming about family medicine research, I really like this story, which I got growing up. It's a story that you'll hear various iterations of it in the Asian subcontinent, you'll hear in Africa. Pretty much, we know, I'm not sure if it's ever made its way to North America, but this is a story which, as we heard yesterday, Sarah Kim, your creativity is still in you, and I will say that your inner researcher is still in you till somebody told you you can't do it or you're not a researcher. Basically, our minds are geared to be researchers. We're always asking questions. We're always seeking to understand. We're always trying to make sense of things. And so, when people come across this piece of research, the story talks about 3 blindfolded men in a forest coming upon what is an elephant, but each one touches a different part of it and is convinced that they've got the right answer. So somebody thinks the trunk is the snake, somebody touching the foot is thinking it's a tree, and the other holding the tail thinks it's a noose. And they start arguing. And really part of the work to be done was to help them take their blindfolds off and get the full picture as to what it is. And this is exactly what I think we need to think about, how what family medicine research is. When you look at our department, we are all touching different parts of the elephant, but at the end of the day, we are nurturing this elephant. And for those of you who don't know me, I love elephants. But talking about elephants, we can't ignore the elephant in the room. If you're a researcher, as some of you may know, we've had a huge investment in something called Utopian, which is our practice-based network. And although parts of Utopian are on hold, for example, data collection from the sites, because we are transitioning into the Poplar network, which is broader, as well as responding to an anonymous complaint made to the Privacy Commission. We are on hold of collecting new data, but all is not lost. I think we can still take care of this beautiful elephant that has grown over the last 10 years, which is Utopian and has impact. You heard about it yesterday. The data is not all lost. The data is now secured. It's allowed. If people want to do research, they can apply to REB, get an REB approval, and use the existing data from all the sites over all these years for any research question they might have. So all is not lost. And there's a large team here working with Michelle, with Tara Marie Watson, who's joined as our new Associate Director of Research, the Privacy Officer, the legal at Temedy, and all of us to create a submission to the REB so that we can get an approval for Poplar. So I'll put that out of the way, and we'll let the elephant rest for now. But if you have any questions, feel free to ask later. So what how do I come to this? When I was the acting vice chair, and I took the time, and I was supported actually very graciously by the department and the acting chief, David Tannenbaum, to conduct an environmental scan. And so with Marianne O'Brien and a whole bunch of people, we did a literature and document review, semi-structured interviews, 6 focus groups, and consultation with the executive. And I personally interviewed 18 international leaders and all 30 DFCM funded researchers, including the directors and associate directors of the Utopian Network, to get an understanding of what is family medicine research. Now, most people, and this is it, like most people, including many of our colleagues, think of research this way. This is family medicine research. It's one flower that everybody has to do the same thing, and then that should be family medicine research. So there's a little bit of variation. Somebody may study the bushes around or the leaves, but everybody's studying the flower, and everybody should study the flower because that's what defines a researcher. It's focused, it's what you're doing. But over time, people have come to understand that maybe there are people in family medicine who are doing more, and it's more than just a flower. And so it's a flower bed. And even, that's what it is. So there are more than one type of flower. So somebody may be doing research into social determinants of health. Somebody may be doing into cancer. Somebody may be doing into disparity, but pretty much that's what they're doing. Or somebody's doing diabetes, or somebody's doing some disease, some body part condition. But they would try to put that and fence family medicine research that way. But really, when I did this evaluation and I got to meet and hear everybody's fantastic research and what they stand for and how they're moving the field forward, I felt this is a better description. Family medicine is the big picture. You are studying a whole host of things. And not only you're studying the plants, but you're also studying the pathways through that. And you're studying the people and the different people who make it. And you're also studying the people who didn't make it into the garden. So I think this ecosystem of family medicine research, no single person can say that they are the best family medicine researcher, because you may be the best in this flower bed, but you're not going to be necessarily best in this bush. So I think we have to take this collective view that there are different ways in family medicine, from seeking to understand, seeking to make sense, seeking to discover, seeking to test, seeking to implement. And all of those things make up family medicine research. So I want to make sure that this department, as we're going forward, is inclusive, and everyone feels that they belong here, and these gates to this wonderful vista is open to all. Now, that was all like sounding all great and inspirational, but this is Chris Meany, biostatistician, did this. He looked at through what are all the issues that people are studying at U of T compared to the other universities. And basically what this tells us, Toronto is here in the, I don't know if I can get the laser pointer on, but I'm going to try, but tell me if you can see it. Here's Toronto. And that's Toronto. And you can see the topics here, which will tell you what are the things that are being studied. So we're trying to figure out a way how to make this more available to people, so we can get an idea of, if somebody wants to study those things, what's going on in which setting in Toronto, and what are the gaps that we need to pay attention to. But I want to tell you, basically, this data, tells us that pretty much we are studying the garden. Now, who studies the garden? There are lots of researchers within the department. We only are able to find partial funding or leverage funding to 31, which works out. And so basically we fund 31 people for a day or two a week, but they get matching funds. When you add up all the time in this faculty of 2,000, we have 16.35 full-time equivalents funding who do research and are funded by us, but they also get funding from elsewhere to support themselves. Overall, these numbers are fluctuating a little bit, but there are about 25 clinician scientists, and in that is including one full-time PhD scientist, 2 clinician investigators, 2 graduate students and family docs pursuing graduate studies, 1 a master's, 1 a PhD, and 2 new investigators. So we're getting up there. And also this doesn't tell the full story, but we do know that the ratio is 59% are women and 41% identify as male. And we need to do better. We do know that there are barriers, but we certainly need to pay attention to this one. And it is going to be one of the things I pay attention to, because the future of family medicine research is going to have to evolve to make sure that women can actually thrive in this environment of research. And it's not what, the status quo is not going to allow the future family physician researcher to survive in research if we don't make some radical changes. We are a collaborative bunch. We have 72 researchers affiliated with DFCM, produced 5,000 unique research publications. Again, this comes from Chris's work. They included 236,000 collaborations, of which 8,000 were unique. So we create relationships. So there's continuity of relationships even in research. And the community from an extensive interconnected collaborative network of local, national, and international levels. As you take a look at those dots are basically the network. And this clustering in the middle really is a testament that investment in people like Rahim and Chris are paying off. Having core central funded researchers really allow, in a distributed model like ours, for researchers to flourish. Now, here's where it can get. And what I want to do that is get you to this is going to be a bit of a thing. So yeah, we can beat our chest and say, oh, we are great. We are just, a few publications behind Oxford. And we are being cited, number 3 in citations. Wow, look at us. But I want to get us to be a bit humble because these things don't tell the whole story. One of the biggest issues when we do research, and I think this is the issue that we have to think about, is something called research waste. And this is something particularly important for us as family docs and people doing focused practice as well, is are we asking the right questions relevant to clinicians and patients? And so for me, Poplar and Utopian and every funded researcher should be making sure that they reach out to their colleagues, not other academic colleagues, but the frontline family practice practitioner working in solo practice or without a team, and ask what their priority questions are. Figure out that how do you include clinicians and patients in setting the research agenda wherever you are. Are the designs and methods appropriate for what you're trying to do? Many people don't do basically they ask the question and they jump in and do the study because they can get funding, but make sure that they pay attention to the existing evidence, reduce bias, and do those kinds of things. So you're getting good quality products coming out. Publish the data. And the other one is often report openly and transparently. So what often happens is a lot of this then goes into the bin. But more importantly, as we look at it, not everything in family medicine can be subject to an RCT, and neither should it. I mean, we wouldn't recommend doing an RCT to see the effectiveness of parachutes. There are some things we just know, and there are different ways of knowing. So that should not necessarily preclude us from making informed decisions with humility, but definitely not just only get blinded by the RCT method for every question. It's not appropriate. The other thing that is happening is we should really do something with all this evidence. It says that it takes about 17 years for only about 14% of data, of findings, to make it into practice. So, and yes, everybody says we should, but there's some real issues that happen when you take research evidence traditionally developed in the ivory tower, then pushed out to practice, and this is what happens. This is Chambers in 2013 created this fantastic diagram. 2 things is, as you're moving and implementing an intervention over time, the intervention it decreases its effectiveness because there's basically been a drift in what was actually offered, and people start cutting things off because they don't understand why it makes sense. Or I'll just change this. The next thing you know, you're not getting the outcomes you're hoping for in time, and that intervention becomes useless. Or as you take something studied in a very tightly controlled environment, and then you're trying to transfer it over, you get a voltage drop in its effectiveness. And there are some studies, especially with antidepressants, where in the trials, the antidepressant placebo response is greater than what the active response is to the antidepressant in the real world. So there's a lot of things that happen of decay and drop. They call it voltage drop in the effect of an intervention. So this is, and this is not to blame primary care. The problem is we are testing in some areas and then trying to apply it broadly in areas where the context hasn't mattered. So to me, this is like you grow this fantastic tall tree in ideal situation, ideal sun, watering, and soil. And then you're putting it out, just throw the seeds into the world where nobody's prepared the soil, there's no gardener to tend it, they're too busy managing other things, there's not enough water, there's not enough light. And you say, how come this tree is not growing? So that's the issue. Another big issue of research that we have to pay attention to is that they typically, because of its nature, are trying to do, I'm sorry, I'm not moving forward for some reason. My slides are stuck. My apologies, but is my slide moving on for you? Nope. It's frozen at my end. Okay, so basically the other issue is that in trials, everybody wants to make everything equal. But the problem is that we have come to recognize that equality is not the best way forward to implement issues. We really need to have an equity lens because different groups and different people experience what we're trying to do in research differently. So I don't know what to do, but my slide has completely frozen, and I don't know. It says wait for the program to respond. I'm going to wait.
Can you unshare and reshare, Peter? Or is
I
that
will. I'm going to try.
Could you close PowerPoint and reopen it?
Okay, I'll do that. What happened? Did it come back?
It's still up, the same slide.
Okay. Okay, sorry about that. So I'll just keep talking until my slides come back up. So one of the other issues that we notice is that the ultimate place that we need to take research is that it takes a justice lens. It's not just inequities, but we're taking a justice lens. And so the questions we ask need to be filtered through that, as well as the questions and the studies we design need to be filtered through that. The people we fund need to be filtered through that. The people we engage in research and communicate and co-develop with needs to be take that justice lens, because otherwise we are not going to find ourselves in a place of really dealing and implement and having a value-driven research program that is consistent with our strategic plan and values. How about now? Do you see it?
Yes.
Just share, go full screen.
I'm going to go full screen. Tell me, what are you seeing now?
Full screen.
First slide.
Yay. Okay, but first slide. So I'm going to do a massive, everybody close your eyes. I'm just going to, I don't want anybody to get like triggered, but okay. So that's where we have to go because the existing system is broken. And so really, this is that slide that I really like, that it take us beyond equity to a justice issues. So we really need to understand how conditions in family medicine interact with each other, but how they get tempered by and worsened by people's social, economic, and social determinants of health. And therefore, if we don't understand how those interact, we don't know which levers to advocate for. We don't know which levers to advise patients for. We don't know which levers we can help people live their best possible lives. And so the other thing is that research impact, as you saw, I showed you all our, chest beating things, our grants and publications, and that's great for a particular audience for outputs. But research impact needs to be different. this is taxpayers' money pretty much in Australia, UK, and in Canada. And we have to say, what is the benefits or returns from research which flow beyond the academic realm to end users of research? And these are the industry, business, government, or more broadly, the taxpayer. So it's not just our patients, it's the society. And really we need to go to think about and measure and report on the impact that we are making. And this is just a slide from Rivera in 2017 that says, okay, yes, sure. It's not to say that realistically sometimes, and as you're starting out, short-term impacts are important. It's not, you cannot have long-term impacts if you don't have your short-term impacts, but clearly we need to do that, but we can't stop there and feel that we've done it. Our job is to move to and work towards long-term impact. But the problem is, if you don't start with what long-term impacts you want to address, the short-term studies you do may be completely inappropriate. So that's the important thing to do, is to have that long vision as to what exactly are we trying to address in research, and what are we trying to impact. Now, we have the ultimate powerful skill set. And one of the things that I like to think about is actually family physicians and family medicine training really takes us from medical school, where you're an oocyte and, before undergrad, and you become this blastocyst and a human fetus. But really what you have are these pluripotent stem cells, because you can differentiate depending on the circumstances what is needed. In day to day, you're dealing with circulatory system issues, nervous system issues, immune system issues, social issues. And this beautiful skill set should be enduring, because we can think differently about situations that come up in front of us. And to me, this is the beauty of what family medicine research can be, is that we embrace and develop a way of doing research that isn't interchangeable with what a cardiologist would do, or a unipotent researcher would do. We have to figure out a better way to define, when you look at that research and you look at the study and you read it, you say, you don't have to look at the name. You'll say, this was done by a family physician. And that's where we need to get to. Again, I am freezing. Oh, no. But having said that, this is all high and mighty, but I look at research, and all of us as research from our childhood, it may have gotten beaten out of you, but I really like to go to Nick Pimlott, who I've known forever, and Kat's paper from 2016, this framework about research engagement in family medicine and the competencies and how we progress as a discipline. And I don't know if you've seen this, but I really like this diagram. It's simple, it makes sense. Everyone in our department should have an ability to curate information and separate, hearsay from what is closest to the truth that we can get to. Understanding that, research and science exists to disprove itself. So we don't ask you to believe, we ask you to trust. And trust because the researcher has given you the best possible information, has told you the uncertainty in that information, how much you can trust it, and whether future research will make a difference. But for now, is it good enough for you to make a decision to help your patients? So that those skill sets are critical, especially in this day of tweets where you read the headline and then you read the paper below. It has nothing to do with what there is. So that's one way in which all of us, to me, this is foundational, that we should have, all of us need to do that, because we are competing against Dr. Google and Instagram and now ChatGPT. But you can't replace your ability to appraise the literature and then contextualize it for the person, because you know them. If you have more time and you're interested, participate in guidelines and modify them so that they're relevant to family medicine. And the questions asked in that guideline are relevant and implementable within your setting. Case reports, a lot of things were discovered by family docs who just observe their patients. You see things that other people don't see. You do pattern recognition. You see those if you're doing comprehensive family medicine. If you're doing emerge, you're seeing different things. If you're doing palliative, you're seeing different things. If you're doing addictions, mental health, women's health, you're seeing it with a different lens. and your case reports will read differently than a generic case report. Clearly, when we look at this, quality improvement is another area, and then you're moving into discovery, and then this practice-based research network, professional research, national and international leadership. And I'm very proud to say that we have members of our department all over here, and that's the issue. And it doesn't mean that if you're in one box, you can't move into another, or vice versa, or occupy several boxes, because that's what family docs do, right? We don't stay in one lane, and we shouldn't. So, and I think we welcome that you're able to be free and take that, take your creativity and bring your creativity. So looking ahead, I just want to make sure that, and I go back to this metaphor. I remember a long time ago at one of our family medicine days, Daniel Martin and myself, Ross Upshur, we were sitting in I think it was a Sunnybrook Estates, and went out, and I kept saying, we're at this juncture where we have to be able to look far and close at the same time. And it was really nice to hear that being said yesterday. But you got to know when to look far, and you got to know when to look near. And I think that's the issue, that we really need to do this, because if you purely come from public health, all you do is look far. If you come from myopic medicine, all you worry is about that patient in front of you. And what we have to do is to be able to look and focus both, and know when to look through which part of the lens. And it takes time, and it can sometimes make you nauseous if you don't do it right. So, and frustrated. So I use that metaphor, and I think it's been really helpful for me, because that's what I try to do in my own research, is look far and close at the same time. And it's really an exciting way, as our health system matures, of how we should be conducting research in this far near interface much, much more. And it's really heartening to see the Clinical Public Health Division come up to do exactly that. So basically, here's a long list, and I can certainly share it with you, but basically the summary report, which we submitted to Danielle in preparation for the strat plan, is, these are some of the recommendations. DFCM could have greater impact if its research programs coalesced around key themes with the potential for global impact. And we could start looking on big ideas in family medicine. And we're already doing a lot of big ideas, but we need to articulate what those big ideas and attract philanthropic support. We need to develop our pipeline. A strong pipeline is required. With graduate students, new investigators, researchers, graduate support, and certificates. We have a certificate in research training. How do we help people do that? How do we help the clinician who doesn't want to spend their time doing research, partner like a clinician investigator with researchers, and get compensated for that, so that they can do meaningful participation and have some of those ideas shaped, ask questions asked, etc. Certainly collaborations need to be further strengthened, and we are doing a great job with that. But we can always strengthen them. EDIIA, absolutely, that's our commitment, and that's the lens by which we're going to move forward. Communication, really internal communications with our staff, externally, we need to do a better job with that. And with leadership above, not only with our own chair and vice chairs and chiefs, but also the dean. And then funding, we really need to pick that up and figure out how to fund. We have 20 faculty are funded through chairs, CIHR or hospital chairs, but not all chairs have a research focus. And that's fine. That's what family medicine does. Scholarship, that's great. And we fund about 31 researchers with sites providing matching or greater funds. We have relatively few non-MD, PhD funded researchers, and more the evidence suggests that having them, and we've seen that locally in our own department, but having fully funded PhD researchers or 1 FTE of research really can amplify our impacts. And we really need to think about how to fund that and recruit excellent family medicine researchers for that. Okay, next slide. So what are the challenges and opportunities? Clearly, we need to study the organization, funding, and structure of primary care to achieve the quadruple aim with a focus on equity. And clearly, we have many researchers here amongst us who are doing that. but clearly that more needs to be done. The health, human resource, and roles of family physicians for the future exactly needs to be done. We heard some of it, but really it's use of data, AI, genetics, virtual care models. Here's a situation where we've done automation, and usually when things get automated, things get faster, better, safer. With the adoption of EMRs, I can see it definitely hasn't made it faster, and I'm not sure it's actually made it safer. And that has contributed great to burnout. And we really need to know, as the fabric of family medicine changes, this needs to be studied as to what actually can be done to make sure that people have goodness of fit into family medicine as a career choice, and find it exciting. And in many ways, I guess this is like, we need to select for people who want to lean into this kind of work, as opposed to want to lean out of it, and figure out how to do that. And that research is required. Clearly, do we need to advance and become much more focused in our work on multimorbidity and integrated care, because we can think far and close at the same time. We can manage multiple things in our focus, rapidly shifting it and integrating that story for that person. Do we need to start becoming much more articulate in that area? The practice-based learning networks is an ascendancy, but funding is problematic. And here's how I look at research. If you are not getting into trouble and you're not making mistakes and you're not failing, you're not trying hard enough. Now, of course, you're not being reckless, but you do want to be pushing the boundaries. You do want to be taking that risk. That's what I want to make sure is, how do I create an environment for people that it's okay to say, I tried this and I didn't succeed. And we can say, so what did you learn? And what can be the next step? So that's how do we get that kind of culture in family medicine and distinguish ourselves from other places where it's either publish or perish, but that failures are possible. And then family medicine, how is it the same as primary care, and how does it differ, and how do we articulate that? And then, of course, we don't have enough academic journals to accept outputs, which is a bit of a problem. And I think we do need to figure that out with the college and fund. And it's really interesting that only in Canada, an open access journal like CMAG Open, where they collect fees, is not financially viable. And it boggles the mind when something like that has had all this money from the sale of MD Financial. And, oh, by the way, we can't run a journal. And then try to get into CMAG, where it's really hard to break through that. So there's a problem, and I think we need to fix it, because although most clinicians don't read academic journals, journalists do, and do tweet about it and push it out there. And we have some really amazing people within our own department who, once their papers are published, immediately do the next level, which is tweeted out. And these alternative metrics are really critical to understand how we are having impact. So what can we do? We really need to become that learning health system. We have all the elements, if you want to think about it. We have a backbone organization, which could be the central department, and we have all our affiliated side, the hub and spoke model. And we have the resources here. And if we can collectively come together and not have this unidirectional from central to peripheral, but like a wheel, everything is connected, we can really make a difference at policy and clinical levels. Researchers around themes, how do we create that and create trust amongst researchers so they can trust each other and collaborate with each other, and create spaces for them to meet and do this, and bring junior researchers into their fold, and create that fellowship that is required to really build and keep a sustained research endeavor. We need to have creative funding mechanisms. Funding family medicine is just hard, but it's possible. Here's my thought experiments that I'm going to share with you. We have on average 2,000 faculty. If 2,000 faculty on average donated $1,000 a year, we would have $2 million without having to go to any granting agency. And with $2 million, you could go and leverage that from donors and make that $4 or $6 million. And people say, why should I give 1,000? I'm giving it work. Why would I give 1,000? But think about it. That's like having one less Starbucks $5 coffee, and Starbucks coffee is not $5. Okay, so you go to, second cup or something, but it's having one less $5 coffee for 200 days in the year. Think about that. So we actually have huge power to do that. And some of you may or may not know, and here's where I get practical about it. It's not putting out a bowl to take money from people, but we need to explore things like the tax credits that the federal government gives for investments in research, and see how we can structure that so that people want to fund family medicine research. How do we make a compelling case for what family medicine research, that big garden? We've got lots of topics. How do we get them to a point where we get creative funding mechanisms so we can fund way more than 16.75 people to do research, hire way more PhDs, and really accelerate not only our outputs, but our impact? Think about it. The pluripotent stem cell cannot do much if it doesn't live within a body that has specialized functions. So we need to really think of family medicine as a family of differentiated and undifferentiated cells working together, that our collective is more than each individual cell can do. So I don't make that distinction between, oh, this person's a researcher, this one's an educator, this is a QI, this is an education scientist, that's a clinician. We all have a role here, and one cannot survive without the other. In the short term, you may, but in the long term, no one will. So if we're really interested in this in the future, we really need to think differently and bring that together. So I need a little time check because I've got complete loss of time. How am I doing for time?
We have about 17 minutes left, and
okay,
we'll hopefully have some time for questions as well.
Okay, so within 7. Okay, yeah, I'm not going to talk for 70 minutes. Okay, so let's go and here's what I really want to figure out a way that we need to do a better job is, how do you leverage the eye line that family doctors have in the system to inform research and collaborate with basic to population level scientists across the lifespan? That's what we need to do. If you work in Emerge, I heard you are having an eye line that no one else has. If you work in palliative and you do home visits, you have an eye line that nobody else has. If you're doing hospitalists, you're doing addictions, you're doing mental health, you're doing whatever you do, specialized, sports medicine, you have an eye line that is unique. And how do we make sure this narrative comes together? And which is why I think we try to do the family medicine report. More and more, we need to figure out that story and use those stories as a way to start impacting all the stakeholders who often use the word just a family doctor. So that's what I feel is the work we need to do. And of course, learning health systems is one area, and we are moving towards that. It's really great that the ministry has funded, which is not, this is not a grant funding, it's for the first year, but it'll come. This is the start. The Poplar, which is what Utopian will become part of, but it's these 6 regional practice-based networks and the Alliance for Healthy Communities, which includes the CHCs and some family health teams, and Care Canvas. We've got the elements, and we've got a emerging quality improvement program. And if you put that together, you get a learning health system. And now I'm going to do shameless promotion of my own work, which I was not going to do that, but yesterday having a drive down with Jack Westfall, he said, you should talk about your own work. And I said, well, that's what most previous Earl Dunn lectures did, but really, I don't want to make this about me. But what I'm going to illustrate is what is possible and how we can think about being innovative. So I'm going to jump into that and just share some information of what I've done in my research career, where I wanted to create an ecosystem where I picked a topic, and I picked something that is of high impact: tobacco, smoking, because it kills 48,000, it still kills about 48,000 Canadians every year. So it's like wiping off the town of Belleville every year off the map. And sorry to anybody who's from Belleville, but that's the equivalent. It just doesn't happen in a cluster. It's happening in ICU, it's happening at home, it's happening in cancer centers. That's what's happening. It's robbing people on average of 10 years of quality life. And it's one of those things that there's an effective treatment, but it's hardly used. Less than 2% of people get evidence-based treatment for their addiction. And And this actually, the other reason I picked it is that tobacco exists everywhere. So it allows me to collaborate not only in family medicine, but in mental health, in surgery, in cancer systems, in long-term care. It allows you to do exactly what family doctors are doing, is go and work and poke your nose everywhere. The only department I don't work with is pathology, because I think it's a bit too late to try to get somebody to quit. So bottom line is the learning health system has two parts, pretty much roughly. There's an afferent part where you're getting data from a side, you're analyzing it, you're interpreting the result, and then you're implementing it back, and then you're studying this. And some of you will be aware of this, that this is like a PDSA cycle in a quality improvement, but this is really, you're taking it in a larger scale. And I'm going to talk about the two things that I created. Is first, obviously, CanAdapt was the Canadian guidelines adapted for special populations. We didn't have one, so we co-created these guidelines and with communities to develop guidelines that would work for them. And then we also did an implementation arm, which is STOP. And again, just like how Poplar was funded 1 year at a time, STOP was I got STOP funded 1 year at a time for 15 years before it finally became a program at the beginning of the pandemic. So I survived, so that's the issue. It takes, you have to stick it out and make it happen, because otherwise it doesn't. And you can't give up too soon. And that's what it takes. It takes a career to make it happen. And then, of course, my training program, which is Teach, which helps do that. And so we've got an ecosystem in place. And I think this is what we need to do in family medicine as well, more broadly. But I'm just sharing this as an example and can share some of the lessons learned in making this happen. This is the History of STOP program from 2005. Basically asked the question, how can I best help people quit smoking with limited amount of cash? We can't give everybody, Cadillac treatment. So how do I take that money and the time that the government has given me to spend the money and have maximum impact? And so I adopted something from Russ Glasgow called the RE-AIM framework, which basically says, who do you reach? How effective is the treatment? Trade-off reach versus effectiveness. How easy is it to adopt? How easy is it to implement? And how easy is it to maintain? And when you just take a look at this, all the settings at which we went, you can see what was easy to adopt, difficult to maintain. And so when you're looking to find where people are, you need to think about, and one of the most fun ones which we evaluated was pop-up workshops, because trust me, there are communities in Ontario that do not have the infrastructure to maintain a smoking cessation clinic all the time. And so pop-up clinics became the way to get in there. But notice when I did internet-based enrollments in 2008, 2009, during the pandemic, before the pandemic, we had gotten to these 80% of all these family health teams, etc. Pandemic hit, the enrollments overall went from 25,000 down to 17. And what I needed to do was pull this out and operationalize the internet-based enrollment, which now is enrolling 450 patients a week. And we have taken the burden off primary care, as opposed to saying, what about my special interest of smoking? Yeah, and so really that idea that if family medicine designs studies that have to be implemented in family medicine, you have empathy for what practices are going through, rather than judging them for not being able to do something. So I'm just going to quickly go through. This is I've had to rebrand my lab as the Intrepid Lab, this is not Intrepid that Karen 2 runs. We independently came to it, and this is since 2005, 336. It's now 350,000 because this is a bit old, but really we've created both through healthcare practitioners. 330 sites right now offer it, or people can do directly through Stop on the Net. And here's just a quick graphic about what it is. The other thing that is really important in learning health systems is that not everybody gets to see the impact. And one way to get the impact of the people doing the work is what we do is every week, at the end of the week, we talk about we send out an email with the numbers, but a quote from every thankful participant. And I can tell you, this is what is about having gratitude in work, in research, because these are the qualitative statements that come from people, and you're hearing this. And if anybody's interested, if you go to the Stop on the Net site, you'll see what people are saying, good and bad, about this. And so this is what clinical population health can look like when we're dealing with high impact issues. So I'm going to move quickly. We are not just treating the word well smokers, but we are seeing, we can section this data to tell you they are smokers with COPD, who they are, where they are, how they identify, what their income is, what comorbidities they have. And that's smokers with COPD, for example, and smokers with depression. Who are these people? And because these people come from clinics, we can map which clinic has what level of prevalence and give bespoke feedback to the practice about who needs help and who doesn't. And or we can help take that burden off that practice, if they so choose, to create resources for them to refer the patient to. And so that has brought us to the new model, which is under development, which is the tech virtual care model. And I don't have time. Osnat Melamed is presenting it during the next workshop, so I'll skip it. But really, this is that innovation of how do you create a whole system where primary care, family medicine, and specialty care is connected through technology and a care manager to really deal with difficult issues and taking a systems level approach for people. The other thing is these data are important because we can link these data into ICS, and this tells us really for policymakers an issue about segmenting the population. So if you really want to get complex patients with high healthcare utilization needs, go to addiction agencies. Their median total cost prior 2 years is about $9,000. And how do we get these patients who are seen here to be actually seen here in family health teams where the median cost is a lot lower? And we have to empirically study that. If we've somehow got these patients seen here, will their healthcare costs actually go down? And that's what these data can help us also make decisions about. So basically designing a learning health system there has to be something in it for the individual, the patient. It has to be something for the caregiver. It has to have something for the organization. It has to have something for the funder. And when we align that, that's how things flow. When they're not aligned, something comes in the way and it doesn't work. So really, this is what I mean by a learning health system that we have to study. We have to all have to come together. It's not just the research division or department. It's going to take all of us to make this change. So this is how we can do it. And you need a multi-sectoral team for implementation. So the other thing, so if going forward, I think what I've learned is layer research on the pathways of care, not vice versa. So with this learning health system, with the stop happening, we are able to see the data coming in. The scientists in my team can then go in to CIHR and get a grant, and it takes 2-3 cycles to get it. But they don't have any downtime. They don't have to fire staff because they lost their funding. We have a way to keep the staff funded in that way, so they can do that. The other thing I take in mind is in the implementation is don't try to land the plane to fix it. I always heard that coming into family medicine. So, but often people are asking family medicine to land your plane for even 5 minutes is too much to fix it. You have to fix while you're going in. And the other thing that is happened right now, especially post-pandemic, is we've digitized the dysfunction which was in the analog system, and it's harder to get out of that. So really, we need to think this through carefully about how we do that. And in the learning health system, you have a great option to create pathways, alternate pathways that can override the dysfunction that has been digitized. And then, of course, prevent the digital HeLa cell problem in society, that we need to have fair use of data. And clearly, we're working on that to have either individual or distributed models for consent and protection and transparency and all the things that would create trust in our system. So I want to thank you. I went over a whole bunch of things. I think the future is bright in the city of Toronto for the Department of Family and Community Medicine, including its satellite sites, the people who are make up our colleagues, both in family medicine, outside of family medicine, the wide networks we have. And I do want all of us to come to this with a spirit of generosity and curiosity. And there's no question that is not right or stupid. We are happy to ask any question, and clearly we need to do better in engaging people and reduce the ivory tower experience of engaging in research. So I'll stop there. I have lots of people to thank, and thank you so much for inviting me to give the Earl Dunn lecture.
Thank you so much, Peter. That was an amazing talk. I hope that you were able to see all the reaction hearts and celebrations. Just, it was a really amazing and inspiring talk. And I will just personally want to thank Jack for getting you to speak about your own research program, because I think it's such an excellent example of the topics that you touched on, humility, working with community, taking an EDI-centered approach, using big data, finding joy every day at work, which I think can help us to combat burnout. So just really appreciate that excellent example of an internationally renowned world-class family medicine research program. I am going to choose, there are several questions in the chat, which Peter, we might ask you to answer those in writing as we move on in the program, but there's one question that I did want to bring to the forefront. How do frontline family docs in the community practically join existing research projects to provide their perspectives from their communities? If you could just comment on that, Peter.
I think it's really, so it's, you know, when you look at it, there has to be will. There's actually a research done on it. There has to be will, one, that, you know, people want to have, they come with a burning problem. There have to be a place where that will can then operationalize. So there's a context that we have created where people say, yeah, I know where to go to ask this question. And that question may require research, like a study done, or just maybe a lit search done to get the question. So that's one way. The other way is obviously researchers need to make sure that they're available and open and provide appropriate compensation for that person's participation, really in a participatory way. For example, when I look at it, if we're doing participatory research where we have patient partners or people with lived experience, I actually look at frontline clinicians as people with lived experience, not patients, but they're people with lived experience whose expertise is very valid. And we need to create a fair compensation model for them to be involved. It may not make them rich, but it certainly will. The intangibles will compensate for the financials that you're giving. So that's how I would, suggest. I think I'm open to ideas if we need to create some way of people have a better engagement that they can put their ideas or indicate their interests. To date, pretty much the traditional model is only the researchers put what their interests are, but maybe there's more. Maybe we need to ask everybody, what are you interested in? And like learning health systems, it's relationship based. So it goes beyond patient-centered to relation-centered sort of models. And so I think we really need to deepen our relationships with clinicians like you. So thank you for that question. And we need to take it back to the research department, thinking about how do we make it easy for people to find projects that are ongoing and put their name forward. And clearly, one of the things is our investigators, when they're looking at knowledge users, think about a family physician, frontline clinician, or nurse, or somebody in the practice as your knowledge user.
Thank you so much, Peter. Those are excellent points. I do think we have to stop, so I'm going to pass the mic over to Allison. Thank you so much.
Thank you so much, Peter, for that exemplary presentation. As Aisha suggested, there's some other amazing questions in the Q&A. If you have the opportunity in the next few minutes to type out some answers that we can all read, that would be great. And thank you, Aisha, for your reflections and for helping us with that portion.